giving the trainees all those NICU secrets, teaching the families, bringing you physiology and the latest evidence in management of NICU babies. Just having fun with it.
Good evening, everyone. I am so excited to be here this evening. This has been a long time coming. So we are here tonight for Uncharted. This is a conversation between NICU doctors and parents. And I'm so excited to be hosting Dr. Prumfort tonight. I'm waiting for our special guest to come in, and then we are going to get started. But I want to talk about the mission of tonight while we're waiting. Basically, I know as a NICU parent, I had a 26-weeker who spent about 3 months in the NICU, and there were so many questions that I had that I didn't have any answers to. There were so many what ifs and moments where I felt like we were rushed, through our process, and I didn't want that for anybody else. I didn't want that for any other NICU parents, although I know everyone has their own experiences. So what I wanted to do is I wanted to partner with a NICU doctor, a NICU nurse. I was fortunate to get a NICU doctor to join us today to have this conversation. And I'm hoping tonight that your questions are answered. I'm hoping that you can find peace and closure. I do have some pre-selected questions, but you are also welcome to go ahead and submit some comments and questions. So without further ado, I'm going to invite our guest.
All right. Well, thank you again, Ms. Ford, for having me. First of all, for inviting me. I am super excited to be able to talk to your NICU community, my NICU community, through the NICU Doc that I created. And again, thank you again. I'm super excited to start this. So let me just say, sorry. Let me just go ahead and just tell a little bit about myself. I am a neonatologist. I'm sure you guys, being in the NICU, know very well what that is. But again, just as a reminder, that is a doctor that takes care of babies in the intensive care unit for babies in the NICU. I started out my training. I'm originally Latino. I was born in Peru in South America, came here as a teenager, did my training at UNC, went to Duke Hospital to do a residency where you basically become a pediatrician. And then beyond that, you do the fellowship, which is where you train yourself to be a neonatologist. And again, some of you that have been in academic centers will know that you have sometimes on rounds, you're surrounded by 10, 15 people. A lot of that are those trainees that are going from medical school to, internship, to residency, to fellowship, and things like that. And we can talk more about that if you guys want to, whenever. But that's essentially me. And again, Ms. Ford, I as usual, on my channel, I always have to talk about the disclaimer for what we're doing. And of course, this is a fun, friendly chat. I'm going to be as honest and transparent as I can be. But I always do say, for those out there and listening to this live, it's really important for you. I know you're going to have questions, and some of the things that I will say I may resonate. But keep in mind, on this forum, these are basically my opinions. I am an expert in the field of neonatology. However, I do not speak for all neonatologists or pediatricians. And also, it's really important, should you have questions or anything, make sure you always follow the recommendations of your neonatologist, your pediatrician, always. But again, with that said, in this forum and this friendly forum that we have, I'm going to try and answer as many things as I can.
Awesome. Thank you so much again. As he gave his disclaimer, I'm also going to give one. I forgot introducing myself. So the opinions, the things that we speak about tonight are simply that. It's just friendly advice. Please do not take any of the things we say or use them in the stead of your doctor's professional opinions. We cannot answer any specific medical scenarios, but we can answer anything that's hypothetical, any questions that you've had lingering, but we cannot give medical advice. Okay, so take that, and we're going to go ahead and hop into our very first question. I want to thank all of you guys who submitted your questions. I was even getting some last night. Thankfully, they kind of tied into what we already had. So, Dr. Prim, don't worry. Nothing's going to catch you off guard.
All good. All good. I'm ready.
Okay. So, question number one. As a NICU doctor, how heavily do you weigh the opinions of the family in making care decisions? They gave an example, and they said a family doesn't want a trach, but the baby is still intubated, 4 weeks corrected, despite multiple extubation and steroid trials. So how heavily do you weigh the wants and opinions of the family?
Well, thank you to the person who submitted that, because that is such a big topic, and actually a topic in itself that we could have and discuss. Because I think medicine has really evolved. We used to practice as physicians, whether you're in the NICU or anywhere else, we used to practice a type of medicine called paternalistic, which is basically we would go ahead and tell the families, you are taking this, here's your prescription, go ahead and take it home, and no questions asked. And you better not ask a question, because, and thank God that medicine is long gone. And now we really do, well, honestly, we've realized that you have to have the family involved, especially in a case where you're talking about babies. The NICU is one of those fields that you're really not just focusing on treating the baby, you're treating the whole family.
Absolutely.
And so it is important to make sure that you get buy-in and understanding and knowledge from the whole family. So when you're approaching, and specifically, I'm going to use that, continue with that example of a tracheostomy, that is not a decision that's done lightly by anybody, by either side. We don't, when we do our rounds, we are always thinking about what we're going to be discussing on each patient before we actually start rounds. We don't take it lightly. We don't go from one day to the next and say, well, I guess it's time for a tracheostomy. Let's go ahead and get it done. These are usually things that you've been thinking about. I can tell you in my center where I work at, we actually have a tracheostomy team, which involves, it's a multidisciplinary team that involves the ear, nose, and throat doctors. It involves a lung doctor. It involves obviously us as the main team. It actually has a psychologist. So it's such, we always say, right, it takes a village to take care of a baby, right? And when it comes to those really difficult decisions, you cannot make it on your own. So to specifically answer that question, we must, it's not a thing of whether we should, we must make sure that we have the input and the understanding from the family. And we really do take that into account. Our job is to essentially educate, give you the options. One thing I will say specifically to that type of an example is that we used to be so timid or scared, if you will, of doing these procedures. And what would happen is you would have babies that would be in for 6, 7, 8 months old. Even myself, when I started practicing, I would say, no, don't, I wouldn't recommend any type of thing. But one thing that we've realized is that the longer that a baby stays laying down, face up, it doesn't matter if your program has, we have music therapy, and we have so many different things. And I know the parents are amazing in helping with neurodevelopment, and I've seen parents come in and read books and so on and so forth, but it's not the same as being at home, smelling mom's cooking, some dads maybe, listening to the sisters' music in the background. Different stimulations are important for neurodevelopment. So the longer that you prolong some of these things, it's always a balance, but sometimes the longer you prolong these things, the worse it is for the brain. And some of the surgical things can be fixed. Even a tracheostomy, once you outgrow the lung problem, well, you basically close that hole and we could be back to normal. The brain doesn't work like that, So once you've lost some of that development of the brain and the growth and all that, it's hard to get that back. And so that's where we always have to, there's no right answer for this. This is where you have to involve the family. But we do, once we begin to realize with our data, we use a lot of what is called evidence-based medicine, which essentially we look at all the data that we have and we determine, is this the right time now to approach the family? And with that, you use all the tools of your hospital to be able to help the family make this decision. You don't make the decision for the family. You help the family walk through the decision. And if they decide this is not the time, they may decide to, come back and readdress that at a later time. And that would be fine too.
Awesome, awesome, awesome. I know for us, NICU parents, feeling involved is everything. Feeling like we have some kind of input. If you don't have a NICU baby, you may not understand this, but when you have a small baby, you have to ask to hold your baby. There's wires and you have to do that. And it's not always like, sure, sometimes the nurse is busy. Sometimes they have other things going on. So you feel kind of powerless. You have to ask to change diapers. You have to ask to hold your baby. You know, things that if you were home, you would willingly be handing them off for someone else to do, but those but little things that you take for granted, you can't always do in the NICU. So feeling involved in the medical decisions is huge for our NICU parents. So that's really good to know. Okay.
Absolutely, and we can definitely talk more about that as we, jump in through other topics.
Absolutely. I do believe we're going to end up circling around with that one. Question number 2. Let's talk about statistics for viability and disabilities. This is huge. I actually did a series on this on my blog. I did a 22-weeker week. I did a 23-weeker week where we highlighted the stories of these babies, and I was amazed at the difference in the numbers. So this person basically posed the same question. Why do the statistics and the numbers of viability differ so much? One mom may be told her 23-weeker has a 20% chance, but another is told a 60% chance. Who comes up with these numbers? Why the differences? And do you feel the numbers are swayed to scare parents, or what do you think is causing such a fluctuation in numbers?
You obviously have some really smart NICU parents, but I'll tell you what, in general, I just find that NICU parents are smart. I mean, you have to read, you have to know, you have to be an advocate for your kids. So rarely do we, find a non-engaging, parent. And actually, when we do, I get a little bit worried because usually everybody's very involved. So that's an excellent question. Let's get to the statistics. And let me run through the statistics, and then we're going to be talking about the difference in statistics. Because I know the question specifically, why is there such a variety? And we're going to get to that. But let's actually talk about the statistics. So, there was a wonderful study that was done. And again, I don't want to get too nerdy, but there was a wonderful study that was done basically by the top 18 hospitals, 16 to 18 hospitals in the country. They're basically level 4, so the highest level of NICU you can get. What this study showed was that at 20, and this not only looked at where we are now, but where we were in 1993. They basically look at the progression of statistics, which is always fun to see. What we see is that babies that are born at around 22 weeks of life essentially have really only a survivability, meaning the ability to survive, of 3 to 5%, which is very low, and unfortunately that number hasn't changed that much. So we're talking about, unfortunately, a great majority of 22-week babies die. And what is even more dramatic is that we're just talking all comers 5%, but when you take into account that there is just, surviving is not enough. You've got to survive with an intact brain. And so that's called, neurodevelopment, or neuro impairment is the part where you actually have brain problems. And well, I'm just going to use the term brain problems, but for the studies, you can look it up. It's, neuro impairment. So if you have brain problems and you survive, really, there's only 1% of 22 weekers will survive without any brain problems. So we're talking about 1 in 100 babies. So that's abysmal. That's very low, but it also is an indication, and the fact that it hasn't changed since 1993, and I'm going to go through the other gestational ages. The fact that it doesn't change, it tells you that where we are in medicine and where we are in science, you can only get so much. You can only go so low before you realize there's also God and anatomy plays a really big role. Yeah. And that's why I think through 20, 30 years of research, we still haven't gotten to a point where we can go below 22, 21 weeks of gestational age and do that safely without causing brain problems. And it's just, again, the anatomy, so the size of the breathing tube that you put in. There's a certain point where nobody makes a size smaller than that. So if you have a baby that's born at 21 weeks, that's, the ones that lowest I've seen and survived was like 327 grams is extremely small, and even they're very challenging. But So there is an anatomical edge point, if you will, of survival. Then we get to actually 24 weeks, and this used to be historically only 10 or 1 in 10%. So, 1 in 10 babies would survive, and now we're actually getting to a point of 25% survival. So 25% of those babies will survive, and really only about 30% of those you'll survive, and you have about 10 to 15% do not have brain problems. So that's going from 1% to 10 to 15%. And then when we get to 25 weekers, you actually now have a survival of about 50%. 1 in 2 babies at 25 weeks, where we are right now, will survive, which is amazing. And 30%, so 1 in 3 babies will survive without major brain problems. So that is a part that has really advanced. We've really made a lot of scientific improvement through research and other things that have gotten us to go from the 23-weeker, 24 and 25-weeker to really get to a point of survival and do better. And we continue to improve and continue to do research to try and get those numbers to be better. Okay, now let's talk about why is it that, my center told me that, nobody will survive. My center told me that, I think we can do really well. That has to do with a lot of different factors. First of all, and I tell this to all parents, when your baby is born, or actually when we do our consult, so we'll go see the moms before they're born, and we, I always kind of joke. I say, keep it in there, let it do a little bit more cooking, let it simmer a little more, because one day makes a huge difference. And that's why there's a variety in the numbers and the statistics, because a 22-week and 1 day will actually have much, much higher mortality than a 22-week and 6-day-old. Mm-hmm. That 5-day difference does not seem like anything to us. But, hey, God created the earth in 6 days. So, we're trying to do the same in an incubator, in 1 day makes a huge difference. So there's one big variety. The second thing is also the center. So there are 2 types of treatments, where one is called comprehensive treatment and the other one is selective treatment. Again, not getting too big and nerdy on this, but what that means, comprehensive center is basically a center where it's multidisciplinary. You as a neonatologist, you're getting together with the OBGYN, you're getting together with the maternal fetal medicine specialist, and that's a specialist that really deals with premature babies. You're getting together and saying, we are doing absolutely everything we can to help babies. That means if we're really young, we're giving the steroids from the get-go. We're not going to consider the mom, We're giving the mom steroids, which really helps to mature lungs. We are going to go ahead and monitor the baby so that if anything goes wrong, we'll do the C-section or we'll do whatever it needs to be done to help that baby. It's very hands-on, heavy, let's go, let's do this, let's do the best that we can for preemies and for babies. So that's the comprehensive form. The selective is actually one that says, where the group actually will come into the parents and say, well, what do you think about having a baby that's premature? Here's the data, here's all this information. Now, we'll let you decide what you want to do, and so on and so forth. So, or an actual physician will come in and sort of make the decision, if you will, to say, there's nothing that we can do. And I know that's always a heavy charged comment, and we can talk about that later. But the difference is that in a comprehensive program, in a comprehensive NICU program, they actually have better numbers. Mm-hmm. Basically, when everybody gets together and says, gun-ho, we're going to do this all out, we're going to go and save babies, and no matter what, we're going to do it, the babies that survive tend to do better. Mm-hmm. Okay? So when everybody's on board. So there's a discrepancy in numbers as well. And then the other part is, obviously, if you're born in a small hospital out in the community, the numbers are just not going to be as good as if you're born in a level 4. Again, that big, huge unit with all the specialists. we're very used to, in my unit, mine's a level 4, we're very used to dealing with, really, really, really tiny babies. And so you have a lot of experience, you use all the data. Smaller hospitals, they might not be able to put a breathing tube in a 22-weeker, and unfortunately won't be able to survive. So that's the other thing I always tell for families: if you're a high risk pregnancy, go see a high risk doctor. You do not want to take the chance of being born in an outside hospital. Having said that, if there's an emergency and you are out there and something happens, do not drive the 3 hours to the big main hospital when you have one 30 minutes away, because otherwise that could also be detrimental. So again, if an emergency case, you go to the closest hospital, and then they will fly you, transfer you. We go pick up, babies from smaller community hospitals. But if you have the choice, if this is planned, you want to go to the big, main hospital if you can, if you're high risk. Sorry, that was a long answer, I know, but statistics is always
necessary. Very necessary.
Statistics is always one of those things. Yes, I want to make sure. And again, I'm happy to elaborate on any of these things as we kind of go through this live.
Wow. Okay. Well, that makes a huge difference. Definitely the level of facility. I know there are some facilities, while I was doing my 22-weeker study, I found that certain hospitals have like amazing survival rates and have been saving 22-week babies for like 17 years.
Absolutely.
That was like new to me. I'd never, known that. I knew a very few 22-weeker babies, which was just incredible to me. So that makes
absolutely
sense.
Yeah, you can get as high as 40 to 50% to even 60% survivability in these big centers. Now, you also you have to be careful with what you read and where you read, because you'll actually get some hospitals that will say, oh yeah, 90% of our 22-week babies will survive. And what ends up happening is that it's not that they're fudging the data. Obviously, no one would do that, but essentially their sick 22-weekers are sent out to the bigger hospitals, and the really great looking, amazing 22-weeker. I mean, probably 22 weeks is probably an exaggeration, but we're dealing maybe with a 24-weeker. 99% survive. They send out the sick ones to the hospital. So yes, the ones that they keep survive, because they keep obviously the ones that are doing really well and send out the ones that are not doing well. So again, always have to be careful with how you read the data, but that's where, again, any discrepancy or any questions, that's where you talk to your medical team.
Absolutely. Okay, so we're going to jump out of our questions for a second, and we're going to go into the things that NICU parents want doctors to know. So I'm going to shoot one at Dr. Prim, and Dr. Prim is going to shoot me one thing that NICU doctors want us NICU parents to know. Okay, so the first one, and these are all viewer submitted. I do have a personal one that I'll shoot last.
Always, a
viewer statement, and it says, what we want NICU doctors to know is to please try and remember that most of the time when you first meet us, most of us are confused, scared, and emotional. Although we hear what you're saying, we may not immediately understand or even want to receive it. Questions may be asked multiple times. Please don't grow frustrated with parents in those moments, because it may be the last thing that they need.
That's and I thank you again for that person who submitted that statement. We take it to heart, and it's so true. When as a physician, you live in the NICU. As a neonatologist, we live there. We go in. We this is what we do. We've been doing this for many years, and you kind of go. And sometimes even with even with the new parents, you forget. For us, it's, oh, here we go, another 23-weeker, and I've got to think about, okay, the fluids that I'm going to give, the antibiotics that I'm going to get, what ventilator, and we're thinking all the medical. And then there's a parent sitting there. And that's where you have to make such an emphasis. You cannot go in and say, oh, okay, yeah, we're going to do this and that. They'll hear, like you said, they'll hear 10, 15% of what you say, because at that moment, all they're hearing is fear, scared, oh my God, 22-weeker, it's an overwhelming environment. So I think repetition, extremely important for us to do. The other thing too, I'm actually, honestly, and I don't know, I mean, I'd love to see what parents think about this. You as a parent yourself, but also some of our parents that we have right now. I always celebrate the moment. That because you walk in there, and I usually say, hey, congratulations. You just had a baby. Yes, it wasn't what you expected. It wasn't your, dreamed of full term with the whole family around. It is a very sick 22-week baby, 23, whatever it is. But we got a beautiful baby, and we're here, and we're alive. And you have to try and still celebrate and congratulate the moment. And again, I've never actually asked a parent whether this is the right thing to do. I do this out of my own, personal, and again, not having had a NICU baby myself. It'd be interesting to see what you think, actually, Miss Ford, and other commentators, or other folks on the live. But anyway, I think it's extremely important. Repetition, trying to not overwhelm too. One thing I always hear from new parents is a list of, you either get both. You either get the parents any questions, and then you get any questions, and you get 20 questions. You can't answer those 20 things. And I will specifically tell the families, I'm on purpose going to withhold 19 or 18 of the things you told me, because otherwise your head's going to explode. So let's talk about one thing that we're dealing with right now. Your kid's lungs are sick and blah, blah, blah. And then I come in that afternoon, tomorrow, let's talk about another topic, because again, otherwise it's overwhelming. So that statement, so true. Thank you for bringing it up.
One thing you said about, the congratulations, is that appropriate? I wish that was the energy that was given to me when everything happened. I met the neonatologist right before I got rushed into an emergency C-section.
Ooh.
So literally I was signing anesthesia papers, and the neonatologist is right here, like, there's risk of this, risk of cerebral palsy. Yeah. All I heard was like all of this, like death, fear, death. Like I didn't hear anything like, 26 weeks, have a great nothing. All I got was the rundown of all the horrible things, and it was like, you want me to go into a C-section with this on my mind? Like, how am I supposed to celebrate?
Right.
Well, meanwhile, my husband's in the corner trying to hurry up and call our family because this was not planned. Yeah. It was like such a chaotic time, and I went into that C-section with like, oh my God, how's this baby gonna look? And that's the first thing when I came to was like, where's my baby? Is my baby okay? Had I had a doctor come to me and say, congratulations, we're gonna do the best we can, I think I would have felt like way more at ease. A lot of times when we meet the neonatologist, it's before, not after.
Yeah,
I think it would make a huge difference, if someone came in afterwards and said, congrats, even after I had her, like, I know for me personally, I was in the ICU. No one came and said, congratulations. They were just like, your baby needs milk, and came in with the pump. That was like, okay.
Yeah.
You want to tell me about the milk? Like, my baby wasn't even drinking milk at that point, mind you. But, if someone would have, it just would have made it a lot easier. So God bless you for that.
No, I think it's a little bit of that is unfortunately part of our medical system. Sometimes you are overwhelmed. You are, when we take call, you may be on. Sometimes we do up to 32 hours straight. You're tired, you're exhausted. You've got not only that 22, 23-week preemie, you've got a kid upstairs who's getting really sick. You've got so many things that are going on. And again, not ever an excuse, but it's, again, a little bit of that. You have to force yourself to really understand that at that moment, that family is going to remember you for the rest of your life. It may be those 5 minutes you meet that family. For them, they're going to remember, they're going to be traumatized by this and going to remember that one thing that you said, your baby's going to have a brain bleed. That's the only thing. You might have said, congratulations, amazing, but your baby's going to have a brain bleed. And that's the only thing to remember. So we have to be so conscious in those really, really, really high stress situations. To be, no matter what, you never kill hope. You can't. You can't do that to a family. Now, there are situations where you really have to go. I mean, again, you guys are so smart. We can't go in, sugarcoat anything, hide anything from you. You should never do that. But you also, you can't be all doom and gloom. You have to keep hope But be honest. Your baby's extremely sick. This is what's going on. A, B, and C, and D. We're doing this for your baby. But you can't say, you just can't do that to a family. So that's really important. But again, sometimes, and I'm guilty of it. I mean, you're so exhausted. Your brain's thinking, I've got to get this baby to survive, and you forget that you've got to get the family to be okay first. The psyche of the parent is so important.
Wow. All right. So what is something that NICU, you kind of gave us one, what is something that NICU doctors want us NICU parents to know?
Absolutely. Well, I think a really important thing, and I think most parents really kind of know or feel this, but I want the families to know that when you have twins, triplets, quads, quins, I've seen it all, I want you to understand that we treat every baby like its own individual self. So we treat every baby different. We understand, obviously, they're coming from the same mama. But just like any sibling you have, any child you have, we get these preemies that 2 days, 3 days later, they want that breathing tube out. They're 23 weeks and they're like, this is so uncalled for. Or I'm sorry, I didn't mean, I misbehaved. I'm ready now. I can breathe on my own. They take it out, they do amazing. And their twin is intubated for a month and a half, 2 months. Yeah. And of course, that's got to be extremely difficult for families because obviously they're looking at them like, why? They're twins. They're supposed to do the same thing. This one's eating great. Why isn't this boy? She's doing amazing. Usually the girls are doing amazing and the boys are just lazy. Mm-hmm. So why isn't my boy eating as well? And so we have to emphasize that every baby is different. Their way their personalities, their traits, the way they advance within the NICU is different. So we have to know that as physicians, we do treat them, differently. And I want parents to know that this is why we may come in and have a plan that is completely different to the other twin that, again, might drive the families crazy, but it's because we have to treat them as different. We do, again, take into account moms, that they're both coming from moms, so there may be some things that are similar, but we will always try and treat the twins different.
Absolutely. And I encourage all of my NICU mentees to journal everything for every baby. If you don't, remember what medicine it is or, what their feed got bumped to, journal everything because trying to remember it is going to drive you crazy anyway, even if you have one baby. But when you have two, I can just imagine the chaos of trying to remember who's doing what, who needs what. So it's always important to write that stuff down too as well.
I'd like to make it, Ms. Ford, if you don't mind, I see someone commenting, and I can't quite, is it Sammy Stern, who mentions, I can imagine his part having good bedside manner in a medical crisis like that. And it is true, but it should never be an excuse.
Yeah.
It's like, it's like having a strong discussion with your spouse or your significant other. You still love the person. There's no excuse if you throw a ton of curse words and say, oh, I still love you. You still really should love and respect. And it's the same thing in a crisis like that. Yes, it is extremely hard. And again, we have to understand that when we are in a situation, a crisis, or even a code, I hope no parent has had to live through their child being in a code situation in a NICU, but if you have, it's the scariest thing in the world.
Very.
But we have to recognize, I may not be the one to be able to talk to the mom to let you know what's going on, or dad, or the parent, or whatever, grandparent. I may not be able to let you know what's going on because my job as a team leader, as a main doctor, I have to coordinate the safety of your child, and there's a lot going on, and it looks, I actually call it controlled chaos. It looks chaotic to anybody who's outside, but it's actually really perfectly organized. But what I do, I can't do it. What I do is actually I assign, and we try and do this always, we assign a person to talk to the parent. So as we go into a code, I usually find somebody who has enough knowledge to understand what's going on. They may not be a physician, it might be a nurse, maybe a student, maybe a resident, somebody enough to know to understand what's going on. And I usually tell them, go ahead and stand next to mom, dad, let them know what we're doing, what's going on. And as things progress, we break out of a code to talk to the family. So I understand, and I appreciate that comment. Saying it is difficult to do it, but it is also human to understand that everybody's scared in that moment. But that's not an excuse to act, chaotic, just throwing stuff and screaming. No, you have to still be a professional, and you have to be a good communicator. And if you can't do it yourself, you find somebody who can talk to the family. So thank you for that comment.
Great point. Great point. Okay. All right. This next one, maybe a little touchy. We're going to touch a touchy subject again. If you were not here for our disclaimer, we're just discussing scenarios. Please do not take anything we say in place of your doctor's, advice, medical advice. Okay. Question from one of our viewers. As a neonatologist, you know the importance of the timing and the fragility of our children's health. Knowing this, why do you all push for vaccines so early? They go on to say that their son was born at 26 weeks, and a month later, they wanted to give that 2-pound baby the standard vaccine load of a regular newborn. Is that standard practice, and if so, why?
Yeah, again, wonderful question. Again, speaks to your great, we have some great, smart NICU families. Vaccines, as everybody knows, and I was a pediatrician before I was a neonatologist, so this is what we used to do as pediatricians, and we still practice that within the NICU. Vaccines, as you know, are extremely important to make sure that babies do not get some really ugly diseases. And it is hard. Sometimes I've had conversations with families, and I know that for them it's very hard to imagine, that needle going into that little tiny, looks like a chicken wing kind of a bone. They can be pretty small and tiny. But for the most part, if anything, there's very, very, very little downside to receiving there's really no downside, honestly, to receiving the vaccines. We do know that some babies who have lung disease, for example, may have some within the next 24 hours because the body's reacting to it. That's actually what we want. We want the body to react to a vaccine because it gets them ready and prepared for an actual disease. But we know that sometimes they have these little dips in their oxygen. Long-term affects nothing. We actually know, and we usually try and prepare families to say, hey, we're giving the shot tonight. For the next 24 hours, your baby may have a slight fever or a slight temperature elevation, may have obviously a little pain at the side, little redness at the side, and we may have some little oxygen dips. We know that. We're not going to act on it. So that's the huge, and the benefit, obviously, we unfortunately do see the babies that do get sick from the diseases. And luckily, in this country, we rarely see some of these diseases. Out in other, countries around the world, they really do see some of those, rare diseases because of lack of vaccines. We don't see that because really most babies are vaccinated. But when it comes to preemies, their immune system is not very good at all. They're fighting cells. And so you need to do everything you can to give babies the best chance to survive within the NICU and when they go home. I remember actually one parent told me, well, why do you give shots in the NICU? My baby's been here, it's going to be here probably the next 3, 4, 5 months. We're not going to be out in the world. They'll be fine. They're protected. But unfortunately, adults come into the hospital. Right. And the moment you walk into a hospital, whether you're the adult or family the moment you walk in, you're already at increased risk of infection. Not that you may not have brought it, but we just know, unfortunately, the hospital has more infections than your house.
Right.
And so, just walking through the hospital, you're at increased risk of exposing your child to infection, no matter how many times you wash your hands. And obviously, we wash our hands, judiciously. Even that, unfortunately, viruses are just nasty bugs, and so they can cause these things. So we do see the babies that don't get vaccinated, that get sick, and unfortunately even die. And so the benefits are so much greater than practically no downside to doing it. So for that mom that got that shot, probably was a hepatitis B shot at 1 month, that baby is protected from that bug that once you get an infection, you got it for life, basically. So we make sure we follow. By the way, every neonatologist follows the American Academy of Pediatrics. So they're not doing this on the whim. They're not saying, yeah, it's probably, feels like a good day to go ahead and give a shot. No, we follow the recommendations of the American Academy of Pediatrics to make sure that that we do the right thing for babies, protect them from those bugs that can really cause damage or unfortunately even kill babies.
Awesome. Great answer. Great answer. Okay. Okay. Next question. Let's go back up. Let's see. Okay. This one's also a bit touchy as well. But I'm glad we're getting this in now. Okay. Question number 3 says, how do you come to the conclusion that there's nothing else you can do for a child? Do doctors ever admit to patients' families that they've run out of options and that they're playing the guessing game?
Yeah, that's you're right. That is a charged question, but something, again, part of this forum, anybody can have a nice little chit chat conversation about how babies are beautiful, right? But I'm glad you're doing this and allowing real questions to come in from parents. The discussion of end of life and deciding when do you come in to talk to a family and have that discussion is extremely difficult and one of the hardest things that we as clinicians have to deal with. I'll get to the actual question and the statement of a guessing game, because I do want to emphasize that this is never a guessing game, but there is a point and there is something to coming in and being completely transparent and talking to a family about the options. So that will be my second part of this, and I'll try not to make it too long and drawn out. But we do know this is the hardest part of what we do, and we do know that being an intensive care unit, all we have in there are very sick babies. Some sicker than others, obviously. And in that same light, there are babies that will be sick enough that unfortunately they do die. And this is where it becomes a little bit more of an emotional, spiritual part of the NICU that you really don't get taught. And if anything, and some of these questions that have been asked, if anything, the rapport, the emotional part of this, these are the moments where it's so important for the families to have established a relationship with the clinical team. And when I say clinical team, that doesn't necessarily mean the doctor. Sometimes, you've seen the doctor for 5-10 minutes on rounds, but you've established a really good relationship with the nurse, or you've established a great relationship with the nurse practitioner. Or if your hospital has palliative care, and that's where it's a group of clinicians that really deal with end of life and chronic babies, things like that. You want to have already established. We don't make that decision from one moment to the next, of course, unless a baby were to suddenly get sick. In general, you are trying every single thing in your toolbox to first of all determine what's wrong and how you can try and change it, improve it, overcome it. If it's an infection, if it's a certain disease, if there's a problem where there's too much acid, we use all our tools when a baby is very, very sick to turn things around and ameliorate the problem and improve whatever the situation is. One thing I always tell families though, and I tell them early on when I've seen a situation where the baby is extremely sick, is that there is a point where as clinicians, we can do a whole lot to the body. We can put tubes and probes and lines and 20 antibiotics, obviously I'm exaggerating, but all kinds of treatments to the body. But I strongly feel, and in my faith as well, that there's a point where you start crossing over and hurting the soul. And that's a part that to me is so powerful, and you have to have a conversation with the family to let them know that, if I'm feeling as a clinician that we have gone beyond and crossed that line, I need to have a conversation with you. And with the same, on that same token, I want you as a family member to tell me when you feel that we're crossing that line. because every parent is very different. Every family is very different. And I may think, oh, we can still do it. No, I'm gonna throw, this. I'm gonna pick out this medication, do all this. I'm gonna put lines and tubes and all this. And a family may be there saying, you know what, I can't handle this anymore. My child is suffering. And so I want the families to know that we are open to that. And I can tell you that probably 99 out of 10 times that I've gone into a family to say we need to sit down about the suffering, 9 out of 10 times most families have said, yes, I've been thinking about it. It usually doesn't come out. It doesn't mean that they're, they've reached a point where they're, throwing their hands up, or that they're ready. No one's ever ready for this.
Right.
But there are ways of approaching this. And then the other thing that we try to do is to take away when you really have to, talk about taking a baby off, meaning you have to take the breathing tube out and you have to give them comfort care. Basically, you give them enough, you don't want them in pain, you don't want them in stress, you give them medication and you give them comfort care. I always tell the families, the onus is going to be on us. So I tell them, I use a buzzword, I use a phrase where whenever you're ready, you tell me that line, that phrase, that word. It could be something like oranges. And that's it. And then I'm going to go ahead and make the decision, or I'm going to go ahead and come in at the moment, and it's going to be me. I'm going to be the one taking your baby off, if you will, so that a parent doesn't go home thinking I took my baby off. No. So usually I've had families use any kinds of words or any kinds of phrases, and then I don't immediately go in at that second, because then it's gonna feel like there's that connection. I said this, and 5 minutes later my baby was dead. No.
Right.
So usually we get to that phrase. I spend a little time, prepare everybody, make sure we have a little time, and then I'll go in and we do it nicely. And I didn't want to get too much into this, but I honestly believe, and this is my own personal belief, so that doesn't mean that all doctors feel that way. And again, I personally believe there is something called a beautiful death. There is something where you can still respect the baby's life, and just like that, you can respect the baby's death, you can respect the last moments, you can respect the family. We obviously talk to the family how you want this done, and we respect that, and we try and respect every wish in that end of life moment. But I do believe there is a way to make this as beautiful as you can in a very, very, extremely difficult situation. So I don't know if that answered that question, but it was heavy statement question, and I hope I was able to answer it as transparent as possible.
Absolutely. Thank you so much for that. I see a question. I want to, it takes us back a little bit, but I want to answer it. We have a question in the comments. It says, are the dosages for a very small baby adjusted accordingly when being vaccinated? My son is 3 pounds, but close to his 2-month shots in the NICU. I'm unsure if we should wait.
Yeah, great question. So we do adjust. We make any dose that we use for babies adjusted. Vaccines is very different, because you actually kind of follow their development more than their actual growth. But yes, we do. So we have there's an actual infectious disease book called the Red Book. We follow those. Again, those are the American Academy of Pediatrics. So we do follow by weights. Any medication that we use is always akin to weight, and that's why sometimes the doses are tiny for those itty bitty babies. The question on whether we should wait, again, I'm a huge advocate of vaccines. I think most doctors are, obviously, but there is very little downside of giving the medication or giving the immunization. There's practically no negative reason to give it. There's really very little, there's no downside to giving a shot when they're supposed to get it. And if usually the medical team is recommending a shot at that point, then it's because the baby's ready. I was just gonna say, obviously, the baby's extremely sick. you might not want to give the shots at that point. And we always have to catch up on the very, very sick babies. They may be 3-4 months before we can give the first set of shots, but those have been really sick. Generally, we've got a clinician already recommending giving the shots. That means that the baby's healthy enough to receive it. Decides to do immunizations on extremely sick, babies. So I would follow the recommendations of your doctor if that's what they would want to do.
Okay. Your sound's been kind of, the volume's kind of coming in and out. We can hear you okay. We heard your answer okay, but I'm not sure if that's happening on your mic end. But okay. All right. So now we're back to another, what NICU parents and what NICU doctors want each other to know. So let's see. Number 2. This is what we want doctors to know from a NICU parent. It says, if you are frustrated with the state of a baby's condition or the lack of progress, please don't show that in front of the parents. It appears to us that you don't really want to care for our children if you express that kind of frustration. That makes it more difficult to leave our babies behind if it seems like the people we are trusting with their lives are seemingly getting tired of fighting for them. Wow.
Yeah. Again, I love the honesty. Can you hear me okay now? Is that better? Somebody was calling me in the middle of the live, and I think that might have had to play with the audio. Yeah, that is that. Hey, thank you. I mean, all I can say is thank you for that statement. It is, again, I mean, we are people. I know that, with people, obviously, once you see that white coat, you think differently of the clinician, but we are people. And unfortunately with that, unfortunately with that, we bring in our biases, we bring in our frustrations. You may have had a terrible day at home and then you're coming to work, or we talked about being 32 hours. And yes, of course, that should never be an excuse. That should never happen. You had a bad day at home. Doesn't matter. You're supposed to go in, be a full professional, be there for the families, but again, I mean, we're human. And so you're absolutely right. That should not happen. And we should be better than that. But unfortunately, it does happen. And we have to catch ourselves. And again, I'm sure I've been guilty. I may not even know it. I may have come in. One of the hardest things that we have to do sometimes, that I have to always catch myself on, is that you may go to a situation with an extremely sick child. We were just talking about end of life. I may have just literally had to be in a room. I've been crying with the families. The baby's just passed, and then I get called to a delivery of a newborn, new full-term kid. And so I'll go there, and I literally I'm crying, just clean it all up. And then right before I knock on the door, I literally go like they teach you in school and acting, change my face, go in, hey, congratulations, so happy for you. Because for that family, they're going to remember, we talked about this, they're going to remember that moment. And you can't go in and say, well, congratulations. That's going to ruin it for them. They don't deserve that. So we have to be conscious that doesn't matter what you're going through. This is being a physician is a service to the rest, and you have to let go of what you're going through to help families out. And yes, we need to be better. And if that's not happening, and you're seeing your clinician always coming in like that, tell them to sit down and tell hey, what's your problem? What are you going through? Talk to me. Because obviously there's something going on. But you can always have a conversation.
Awesome. Guys, we've hit the halfway point. You guys, if this has helped you so far, please hit some hearts. Let us know that your questions are being answered, that you guys are loving the content, that we've worked so hard to prepare for you guys. I want to thank all of you who submitted your questions and your comments thus far. We have a few more to go, so if you've not heard yours yet, hold on. I see we have quite a few. I would say 90% of our audience right now are micro, preemie, and NICU parents that I actually know. So I'm so glad you guys are on here. There are a few organizations, preemie organizations on here as well. So I'm really excited to have you guys on here. So I have a question. This one is pretty well, before I do that, let me say this. One of my reasons for wanting to do this was to humanize doctors. I think, and you said it before, we see the white coat and we think cape. We think superhuman. We think no emotions and just cold. And that's just, although we may have had some negative experiences, that's not every doctor. That's not every doctor's position. That's not the way that they, handle every patient. So I really wanted to humanize doctors. Those of us who may have had, traumatic experiences, traumatic births, traumatic NICU stay. Any NICU stay is traumatic for a parent. Honestly, it can skew the way that you see doctors. So I'm so glad that people are getting to see you without the white coat. They're getting to understand the emotions and the feelings, knowing you guys feel just like we feel. So I hope that you guys, hopefully someone is finding some emotional closure, some intellectual closure through our conversation here today. So, all right, let's go.
I really appreciate it. It's as you go through medical school and you go through everything, you do see folks around, and we tend to be type A personalities. If you don't know what that is, for those that are watching, we tend to be very nerdy and very focused, and just studying and everything you go through. It's a lot of schooling, a lot of study. And there's very little on talking with families, very little on that bedside manner. And so, I can't speak to those that have that are, not having great bedside manner. And we always want to, be out there and improve and grow. And, we should be, as families, and again, as a parent myself, we should be okay to talk to the doctors and reach out to them and say, hey, look, came in and talked to me, this morning, that was a little rough. And I really want, I know that every parent's different, but for me, I really want you to maybe break it down a little bit, or give me one piece of information, not 20. And so, again, we are people, and so please feel free to, we really don't bite. Feel free to just talk to your clinician and say, because we don't know how you are, and yes, we need to spend more time to learn how you are, but we may not have that. And so it's really important for you to say, look, I really like that you do this, or I don't like the way you do that, and then we remember that, and then we work with you to try and help you and your personality to improve things, because we're all there for the care of the babies.
Absolutely. Well, we are counting down. Doctor, I told you about that little Instagram thing that it does where it counts us down. So I want you guys to join us for part 2, okay? Give us 2 minutes. We're going to come right back. We're going to start a brand new feed, and we're going to answer the remaining questions. We're going to give some more things that doctors want us to know. So guys, stay tuned. Come right back. Give us 2 minutes, and we're going to start part 2.
Right back.
All right. We'll be right back, guys.